Mitchell, and I'm one of the co-chairs of the MICRA PhD network. On this call, we also have the other co-chair, Francesca Ortiz, so I'll be hosting the keynote discussion, hopefully making sure everything runs as smoothly as possible, whilst Francesca, I'll keep an eye on any of the questions that you propose. So firstly, just to start with a little bit of housekeeping, this session looks to run between 2 and 3:30 this afternoon. To set out the format of the event, we're going to hear from 3 really amazing people. I'm going to briefly introduce them to you right now, but we'll give a full introduction before each of their presentation. So first of all, we have Jane Mcdermott from the University of Manchester, with special guests that I'll let her introduce too. Dr. Chesney Craig, based at the Manchester Metropolitan University, and Professor Andrew Clarke from the University of Salford. And they will each be speaking about the research that they've been conducting and in the pandemic with older adults. Each keynote will deliver a presentation about their work and then at the end of each talk, we'll take a few questions from each speaker. And then we'll have a more generalised question and answer session at the very end. The session will be recorded and uploaded to the MICRA or Manchester Social Science YouTube page by the end of the week. Don't worry though, you're automatically muted with your camera off when you've entered this session. You'll be able to ask any questions that you want to using the chat button at the bottom of your screen, but you can also interact with us on Twitter by tagging us at MICRA PhD Network. So now I'm going to hand over to Professor Alistair Burns, the MICRA Director, to give an introduction to our event.
Louise, thank you very much indeed, and I'd just like to say what a great pleasure it is to be here to say a few words of introduction. It's been a really strange year, but I think the vibrancy and the commitment of colleagues, I think, has been extraordinary. We know that particularly for older people, the isolation and the various regimes has been very trying, and I know from my own clinical practice that people with dementia have, their families and carers have found it particularly difficult. As director of MICRA, I've seen a number of the specific projects that we were going to hear 3 about today, about particularly the issue of older people, and we've run a series of webinars on the issue of COVID. As Louise has said, we're going to hear from 3 key speakers today, and I think it's particularly good because collaboration is key, and as Louise has said, we've got one person from each of our partner universities, Manchester Metropolitan, the University of Manchester and the University of Salford. And as director of MICRA, that the collaboration is really key for that. Thanks to everyone who's been involved, the PhD network is really one of the jewels of the crown of MICRA. You are our future. You are the people who will take us forward. And so it's a great pleasure to support and to listen to this. Thanks to Louise and Francisca particularly for running the network, to Suzanne Booth for all the work organising the webinars, and for the 3 speakers today. But most of all, you have taken the time to listen. And MICRA prides itself, as I say, in being a network, and hopefully by sharing ideas, by listening to the things that we'll hear today, it'll stimulate curiosity, maybe stimulate an exchange of emails to take things forward. And that would be one of the great successes of MICRA. So you've heard enough from me. Have a great afternoon, and I'll pass you back to Louise and Francesca, who are going to take us forward. Thank you very much.
Thank you so much for that introduction. We really appreciate it. So now I'm going to hand over to our first speaker, Jane Mcdermott. So Jane is joined by 2 co-speakers, and I'll let Jane introduce them. I don't want to take any shine off of it. Jane has a portfolio career that involves working across a number of organisations as a consultant and senior programme manager in the fields of healthy ageing, policy and social inclusion. Jane is a member of the Healthy Ageing Research Group within the School of Health Sciences, with work focusing on translational research, promoting evidence-based implementation and practice. She's been working across Europe as a member of the European Innovation Partnership on active and healthy ageing, whilst being a founding member and key operational lead for the European Falls Festival, and contributing member to the Greater Manchester Active and Healthy Ageing Group. Jane's talk today is going to focus on the work behind keeping well at home and keeping well in winter guidance documents, which is a Greater Manchester collaborative response to enable older people and those shielding to remain active, healthy and well during the national lockdown measures. So over to you, Jane.
Thank you, Louise. That was a really lovely introduction. I think you actually introduced me very well there. So I am based in the University of Manchester. I'm part of the Healthy Ageing Research Group, and I also work as Policy Research Unit Programme Manager, working directly with the Department of Health and Social Care, advising them on the latest evidence and also on the lives of older people. I'm just going to introduce two of my co-presenters today because I've asked a couple of colleagues to come along with me who I've been working with really closely over the last 12 months, specifically on this piece of work. So Jill, can I pass over to you, please? Jill, are you there? Is Jill unmuted? Can I just check? Have a quick look. I'll go to Elaine then. Elaine, are you there? Can you hear us?
Yes.
Hi, Elaine. I'll go to Elaine first then. Elaine, please. Hi.
Thank you. Thank you, Jane. It's really a privilege to be here to ask to speak on this platform. My name is Elaine Unabu, and I am the Greater Manchester's Older People's Network Chair of the Steering Group. I have been connected to MICRA, and one of the most exciting things I've been involved with was a piece of research done a number of years ago, where about over 50 PhD students from all over UK were invited, and also 16 older people were invited. And we were each paired off with 2 students. And they were to explain to us what they did, and we were to ask, how would this help older people? It's something I'll never, ever forget. But not only did I find it so exciting, the students also found it exciting because they were all from different disciplines. You know, and being and continuing to be involved with MICRA, it shows, you know, I've had a lot of learning, and we form new relationships, and that I think is key. Thank you.
Thank you, Elaine. That's great, and shows that the tradition of us ensuring that we work intergenerationally for many years and making sure we're linking up all our students with all the different networks and people that live in our local communities is really important to us in Greater Manchester. Jill, are you live? Can you?
I hope so.
Hi, Jill.
So.
We lost you for a moment then. Hi, Jill.
I know. Wouldn't it always happen to me? Okay, good afternoon. Good afternoon, everyone. It's a great pleasure to be here with you today. It's my first time at the meeting, and it's great to be in such august company. My name is Gillian Stainthorpe. My friends call me Jill. I'll answer to either. And at the moment, I'm the Greater Manchester Older People's Network representative on the steering group for Bury. And I got involved with the Greater Manchester Older People's Network after I retired, and I needed something to do. I needed something to keep my brain going, and it sort of snowballed from there, and I'm getting more and more involved, and I really sort of feel to myself at some stage I'm going to really get out of my depth. But at the moment I'm enjoying it. I'm the chair of the Health and Social Care working group, and that working group has quite a few members of the network on it, and it's a focus for people to raise the issues that most concern them, and hopefully we can do something about it. And this was one of the issues that we actually looked at. So I'll go back to Jane.
Thanks, Jill. So we just go to the next slide. So rather than me do a traditional presentation, myself, Jill, Elaine have been involved since last March working together on this piece of work, which is keeping well at home and keeping well this winter. We've actually got a short film for you to watch. It's about 9 minutes long, but it tells you the complete story from start to finish of the last 12 months of a piece of work we've been working collaboratively on. I think it really captures everything in terms of what we've been trying to achieve as a group. Whilst you're watching the film, because it is quite long, and we would like to give the opportunity afterwards for you to ask some questions, but please feel free to use the chat. The chat function, you should know, is the little bubble. You just pop it up and then you can type directly into it. And feel free to comment on why you think the campaign has been so successful, what you think you could learn as part from this process in terms of collaborative action and what good collaborative action looks like. And also what you might learn in terms of your future research and how that might influence you or impact on you in terms of how you approach your own research. And then also, of course, if you've got any questions for myself, Jill, or Elaine, then certainly we can answer them at the end of our little film, but also then potentially at the end of today's session. So I hope you enjoy it. Do keep watching. I think it's Suzanne who's very kindly going to share her screen and play the film for me. Thank you.
Just before national lockdown, I convened a meeting of the local lead officers for ageing in the 10 local authorities, really to understand how at a Greater Manchester level we could best add value to the work they were doing, to hear what the needs of older people were and what resources we could find and share.
We were listening to people's experience, what was happening across the city. And we started to really think, how do we ensure that people stay well at home? What do we need to be doing? How do we need to change the story that was maybe coming out of central government? How do we need to make sure that the communications that we're using isn't just digital by default, but is actually more inclusive?
We were lucky because down to the relationship that we've had with the University of Manchester and the Healthy Ageing Group, we were able to combine, I think, the expertise from the academy with the networking and convening powers that we had. In consultation with the Ageing Hub and other partners, the university decided that we could do something a bit more practical to support people at home and get a paper resource into people's hands as so much information was coming out.
We were getting intelligence and offers of support and need, which would help to shape what this booklet might look like.
I was asked what sort of issues were significant to our residents, what sort of questions they were asking our frontline staff. So we talked about things like helping with repairs, welfare issues and issues of loneliness and isolation.
From partners at the university, it was very clear that there was information that they could share around fall prevention agenda, and that was very much evidence-based. We also had partners at the GM Nutrition and Hydration Programme, and we also had partners at Greater Sport who again had more information on the exercise and how to stay fit.
Some of the content that we supported with is the strength and balance messages. We know that that plays a big part in terms of deep conditioning, so making sure that they were part of the booklet was key for us.
All the people, they knew what they were talking about. So it was good to get information from them.
It's one thing as a policymaker to deliver what we think older people want, but that maybe doesn't reflect what it is in actuality that older people do want.
I just thought this is fantastic because older people, COVID, we are indoors. We were constantly having negative communications via the media, and it was all a downhill. What are we going to get to give us some kind of positivity? And I just thought this was brilliant.
This book is good because it doesn't negate you. This book is like a silent friend.
What made the booklet such a success is the fact that it's co-produced with older people.
The Keeping Well at Home booklet became a World Health Organization case study, which really put us in a position of being an example of best practice globally.
It was really important to us that not only we created the first version of the booklet and we included older people in that, our experts by experience, but then we needed to check that and say, actually, have we done the right thing? Have we included the right content? Does this really make sense to people? And of course, what have we missed? Because inevitably we will have missed something.
Evaluation is critical because in reality, we all live in a bubble. Evaluation is a clean set of eyes.
A lot of the evaluation showed that people really liked the booklet and that they would like other things to be involved in it.
The evaluation of the first booklet gave us a business case for doing the second booklet, and that resulted in printing 140,000 copies of the booklet. It also resulted in being able to produce a video and a talking tips guide.
I was approached by the Greater Manchester Aging Hub to have a look at the booklet and to look at the content, but to also look at the talking and conversation tips that were a guide for people utilising the booklet, so that if you were a frontline worker and you were talking to older people, then you had pointers, tips, ideas, hints, that kind of thing, in which to introduce both the booklet but also to expand on what was in the booklet.
We needed a couple of translations. I think it was Urdu and Bengali, and we also looked at two other translations in terms of British Sign Language, and the easy read version that came from learning disability communities. But what that enabled us to do was kind of simplify and get to the essence of some of the information. And that then becomes something that you can pass on to other communities where there might be difficulties in kind of comprehending the full, more complex and perhaps even sometimes more technical information.
All of this wouldn't have been possible without a successful first booklet, evidenced by University of Manchester evaluation and consolidated by a case study with the World Health Organization.
We've got just shy of 1,000 people that we could literally, the books arrived, the envelopes were ready. They went in the envelopes and they went out.
In Rochdale, we've got them into the vaccination centre. So not only do the older people get a jab, which is fantastic, they also get the Keeping Well in Winter booklet.
In Greater Manchester, we started from a very strong position. We had existing relationships with a wide variety of partners that we could easily pick up. We already had partnerships with the University of Manchester, as well as close working relationships with the 10 local councils that make up Greater Manchester. We also were working in partnership with Age UK, with some housing providers and with some older people's groups.
There is an ageing hub and there is proactive work in older people as a priority of the combined authority. That's also helped by having an older people's network, both for Manchester and Greater Manchester, where you can draw on the experience of older people to make sure you're getting it right and you're doing it with people, not for people.
Because I'd been so involved, I sort of had a bit of ownership, I think, of it.
I particularly saw myself as a partner in this, not as a you and them. I felt very much involved and that our contribution was taken on board.
Manchester in particular has a really great tradition of working together across the age-friendly agenda. So, linking people together, bringing partners together so that you've got people from health, housing, social care, the voluntary sector, policymakers all working together to try and make sure that we make Manchester an age-friendly city.
There is a willingness to give up a little bit of an individual organisation or your individual skills to share with other people and to sort of work together.
You're always a little bit worried when you print something like this. And bit by bit, you start picking up information. You see photographs outside sheltered housing projects where people are holding copies of the document. The document is being given out at vaccination stations where it's been said to do so. You get information back from local authorities in parts of Europe and the other side of the world saying this is a brilliant product. Can we adapt it? All those different ways, they count as successes, I think.
Thanks, everyone. So I suppose I would ask everybody or anybody if they've got any questions for Elaine or for Jill or myself about the process that we've been through over the past 12 months and working really collaboratively. And I think our ability to do what we did was very much based on the fact that we have a really long history of working closely, of co-production, co-creation, and really valuing all the voices of everybody who lives in our community. Are there any questions at all? I'm just trying to have a look at the chat.
Yeah, I was keeping an eye on it, and I already have 3 questions. So I keep them together, in that way I can give it to you, and you can maybe answer in the way that you prefer. So I received a question about any advice to contact with all older people, in which way people can contact with them to do research, and do research in a collaborative way. So it would be great to have more information about, or any advice from Elaine and Gillian. Maybe they both have their own point of view about that. I also have note about after research. What happened when people get the feedback of the research, and how was their experience? Because we saw in the video, you have a feedback survey. So how was that experience from the different points of view, right? Because you are 3 different points of view, and that's super interesting, right? And another question that I received, it was how people can access more information about it, actually. If you can leave maybe a link to that or something like that, you can leave it in the chat. There was people asking about that.
Sure, that's great, no problem at all. So I suppose the first thing is, should we go with the first question then, Jill? If you can just remind me, sorry, you said all 3 of them.
Yeah, it was about the research, about how you contact older people. I think this isn't a thorny question. It's a question that just does need a little bit of thinking. Are you with me?
Yeah.
Oh, that's okay. I thought I heard the booms and I thought I'd gone off again. Right. I think it just needs a little bit of pre-thought about why you need the older people and what the type of research is. Because very often a first step with researchers is to go to care homes or places such as care homes, sheltered accommodation and things like that. And in those particular places, you're getting a certain type of old person, very often ones that can't live independently and often have multiple health problems and difficulties too. I think it's better to look to the community and look to volunteering, those 2 things, because it's my experience that the vast majority of volunteering that's done in the areas that I know are done by older people, and they're very good people to speak to. In addition, groups that are within the community that look to do work with older people, whether that's sort of for social reasons or to teach them to use computers or whatever, you're getting a very different set of people. And I think it's very worthwhile to speak to those people too, to get a really good broad idea of what older people need and actually want. Because sometimes they don't want what other people think they want. So again, that is to be borne in mind.
Thank you. Thanks, Jill. Elaine, have you got anything to add to that?
Yes, I'd like to add that as what Jill has said, collaborating with neighborhood groups, but also I think it's very important that you build up trust of the older person and use the faith groups, and word of mouth is extremely powerful. I think that's what I'd like to add.
Yeah, thank you. I think faith groups are really important as well in terms of going through different community leaders as well and building relationships, and things take time. The only reason we were able to deliver this project at pace, at times of national lockdown was purely because we've got long-standing relationships and we've worked over many years. And we use that. We work very closely with the network, but also the Ageing Hub are very well connected at a local level, and Ambition for Ageing are also very well connected in terms of community groups. So the next question was about evaluation. So for me, as a university, it's really important. We kind of had the idea, we shared it, everyone kind of felt it was the right thing to do in terms of the kind of digital default message, and the fact that actually inclusive communication is really, really important in anything that we do. Not least that we know there's about 200,000 people across Greater Manchester footprint who are completely digitally excluded or living in digital poverty. It depends how you want to describe that. And we know that from that 200,000, about 140,000 of them are older people. So therefore, there's also assumptions that you can be making about communication, and that actually as long as it's on the internet it's fine, but actually it's not. The evaluation told us that, I think it was a 90%, the evaluation report, I can put a link to the report, I can give you a link, it's all live, everything's accessible via websites, and the Combined Authority have the new Keeping Well This Winter booklet, the videos about talking tips, which was developed by older people and delivered by older people and filmed by them as well, about the kind of conversation instigators you might have when you want to find out if your neighbour or anybody that you come across and want to start a conversation with, to see if they're doing okay, or whether you need to kind of seek to get additional support. And so for us as an institution, we wanted to make sure, do people like printed material? Have we done the right thing? 90% of respondents, we did a postal survey, sent out 5,000 during the lockdown, and we got, I think, over about 15% response. And that response showed that people, 90% prefer printed materials. They also really liked, it was overwhelmingly positive. We were actually astounded at how positive a response we got from everybody. It was really quite surprising. But yeah, there's an evaluation report that I can share. I don't know if other people have got any other things about, Elaine, Jill, about the evaluation, why it was important to you, or you thought we should do it?
Yeah, if I put in, I thought the evaluation was very important, because if you're going to go with something like this, you've got to find out whether or not it is actually useful, because I think so much happens to older people rather than older people being involved with something, and so to get their feedback is quite important. I think some of the reason why it was so overwhelmingly positive was because it was targeted at an audience that generally speaking don't have the digital inclusion facilities with computers, smartphones, or if they have a smartphone, it tends to be in a drawer because it's for them, not for other people. And as a result of that, it was finding its home in a right place. And when people feel that something is being done with them, then they're likely to respond a little bit better than if they feel something's being done to them. And I think that was one of the real strengths of this particular partnership that we had. I think it's also important to say that there was plenty of suggestions of new sections that should be added, to the booklet that they wished to have involved. And to be fair, I think would have been in the first booklet, but there wasn't at the time. There wasn't either the time or the room. And of course, as well, we went to great lengths to make sure that the booklet itself was acceptable to older people in its format, the way it read, the language that was used, the tone that was used, all of those things, the print particularly. So many people have difficulty with print on colour and whether there's a real contrast or not. And we sort of minimised the problems and in fact mostly got rid of any issues that might have arisen from that. And I just think it paid off in the long term.
Thanks, Jill. Really valuable points there about that co-design process that we went through to make sure the colours were right, the font size was right. You know, we weren't making any assumptions about who the readers were going to be, and actually just getting direct involvement and feedback from a really quite a broad group of older adults was really, really important. Thank you.
Thank you so much. It was amazing. We really enjoyed that as well, just so we can say that as well. It was really good. Thank you. What we're going to do is we're going to move on to Dr. Chesney Craig. So she's currently based at the Psychology Department at Manchester Metropolitan University as a Senior Postdoctoral Research Associate. Her research primarily focuses on neurological, psychological and physiological predictors of imbalance and falls in ageing populations and neurodegenerative diseases. In order to assess this, our research combines a range of interdisciplinary techniques aiming to inform early falls prediction strategies and maintain mobility and independence in old age and age-related diseases. In her talk today, Dr. Craig will discuss some of her team's recent work on the falls risk during the pandemic, and the talk will present really recent findings from an online survey conducted during the pandemic, which assessed the risk factors relating to falls in an ageing sample and people living with Parkinson's disease as well. So now I'll hand over to you.
Thank you very much, Louise. I'm just going to share my slides. Okay, could you just confirm that you can see that okay?
We cannot see
it. Actually, sorry, there we go. That should be it now.
Ellie's perfect. Thank you.
Thank you. Okay, so Louise introduced this very well. So actually, I don't think I'm going to say anything additional on this slide, except maybe that the idea behind this project was that we all faced a lot of changes during the pandemic. So the project isn't about COVID-19 or anything like that. It's more about the lockdown restrictions that we faced and how that might change our health and lifestyle, and consequently how that could impact fall risk within older adults and people living with Parkinson's disease. So just to begin with, I want to iterate what the importance of measuring falls is and why do we study this. So we know that in older adults, falls are very prevalent, and they become more prevalent the older we get. So it increases to 50% of those aged 80 plus will experience a fall at least once a year. And that this increases even more so in certain age-related diseases. So for example, in Parkinson's disease, it increases to 60%. And actually, Parkinson's is the highest fall prevalence of any neurodevelopmental disease. And so whenever people have falls, around 10 to 20% result in serious injury or hospitalization. But it's not just a problem in terms of injury and hospitalization. Around a third will then experience functional decline, and 60% of fallers will then reduce their social and physical activity. And so basically what we tend to see is a vicious cycle whereby whenever someone experiences a fall, they tend to reduce their activity, and this then places them at risk of more falls. And actually the greatest predictor of having a fall is having had one before. So then recurrent falls become a problem, and as soon as you're in that group of recurrent falls, you're at more risk of having serious injury. And it costs the NHS 2.3 billion each year to treat fall accidents. And in the UK, fall injuries are the most common cause of injury-related death in the 75 plus age group. However, more and more research is suggesting that this isn't just a problem in old age, it's a general age-related problem. So while prevalence rates aren't just as high in middle-aged people, what we do see is a similar percentage of fall-related injuries. And unfortunately, falls in middle age are considerably less studied in the UK. So a lot of the stuff that we know about falls in that age group comes from either the US or Australia. But what we do know is that in the US, falls are the third leading cause of accidental injury fatalities in those aged 45 to 64. So more and more evidence is telling us that we need to start to look at falls and why they're occurring and how they're occurring in this earlier age group so that we can prevent falls before they become truly problematic in old age, where there's at more risk of dying, for instance, from having a fall. From the ageing literature, we do know quite a lot about falls now. It's a really well-studied topic. And so this is just an example of some of the predictors that we know are associated with falls. And the more a person has any of these predictors, the more at risk they are. So the ones highlighted in bold on the screen, I'm not sure if you can see my cursor, but hopefully the bold will be obvious anyway, are basically the strongest predictors of falls. And what hopefully you can see from some of these is that some of them are definitely preventable. So things like inactivity, weight, alcohol use, and mental health, these are all things that we can treat and then try to prevent falls. Fear of falling is another one that I want to draw your attention to, because it's actually quite interesting, because you can have fear of falling without having had a fall already. So what we know about fear of falling is that actually it basically has the same risk factors as a fall itself. And around 50% of people who report fear of falling don't actually have a fall yet. However, just that fear itself can dramatically increase a person's risk of falling. So there's a bidirectional relationship between these two things. And both of these things can severely restrict someone's activity. So a lot of people then psychologically basically restrict their activity, which then puts them at increased risk of all the other risk factors. So within this project, really what we wanted to know, well, how do the restrictions that we've all faced, well, a year to date from today really, impact these? Could they increase any of these risk factors? Or maybe they could even have the opposite effect. Maybe people have more time to be active, and so we didn't really know what would happen with regards to activity levels. But regardless, we were pretty confident that something would change because everyone was experiencing such a different way of life during this time. So the current project basically aimed to examine how health and lifestyle fall risk factors, such as those mentioned in the previous screen, might change throughout the pandemic, and in turn, whether these changes might predict fall accidents over a period of 6 months follow-up. So we used a mixed method longitudinal approach, and the full study took place online. We had 2 parallel arms, and in both arms, adults were aged 45 plus. So we did look from middle age onwards, the way the literature suggests that we should as well. And in the 2 arms, we had one arm focused on people with Parkinson's, and the other arm focused on people who didn't have Parkinson's. And essentially, both these groups of people did largely the same study. It's just that the people with Parkinson's disease had some additional questions that were related to the disease. They all did a detailed initial questionnaire, which I'll show on the next slide, the kinds of things we asked about. And then they did 5 monthly diaries, basically. So these diaries only took about 5 minutes to complete, and they were emailed to the participant after they volunteered for the initial questionnaire. And within those diaries, they were asked if they'd had any falls in the last month. If they said yes, they were asked for more detail on those falls. They were asked if they'd done any physical activity in the last month. And if they said yes, they were asked what types of physical activity they did and how much time they spent on each of those activities. And then they were also asked about this in terms of alcohol consumption. So if they regularly drank alcohol during that month, and what was their typical alcohol intake in a given week. Then at the final 6-month follow-up, they basically did a very similar questionnaire to the initial one. So it was very detailed again, but it cut out some of the trait measures that we thought would be stable over time. So this is an example of some of the things the more detailed questionnaires asked about. The initial questionnaire started off by asking about fall history. So we wanted to know if within the past year they'd had any falls. So were they fallers or non-fallers at the very beginning as well? So this could include falls that happened outside of the pandemic. Then we had some COVID-specific questions that focused on things like living circumstances during the pandemic, because we know that, for example, living alone can increase your fall risk. We had some medical history, so we could look at things like comorbidities and polypharmacy during this time. And we had physical activity, which I've already mentioned how we measured it longitudinally. But in terms of the more detailed questionnaires, we also used the International Physical Activity Questionnaire, which is a longer measure for assessing physical activity. For anxiety, we used the State and Trait Anxiety Inventory. And for depression, we used the Centre of Epidemiological Studies Depression Inventory. In terms of fear of falling, we used the Falls Efficacy Scale International, which is probably the most common measure to use for fear of falling. And then it's not related to fear of falling per se, so I should have edited this bullet point a little bit, but we also measured the gait-specific attention profile, which is basically how much attention someone feels they have to pay while they're walking. And again, that's affiliated with fall risk. We also measured risk-taking using some questions that are used by Stephen Lord's group in Australia. So it focused on basically health-related risk-taking and a few bespoke questions from our group as well. This has started to be studied quite well in terms of fall risk in aging populations, but it actually hasn't been focused on very much in terms of Parkinson's disease. And then in terms of the Parkinson's specific questionnaires, we used the Unified Parkinson's Disease Rating Scale, Part 1 and 2. These are scales that can be completed by the participant themselves. And the Part 1 is non-motor symptoms, Part 2 is motor symptoms. We also ask on freezing of gait and Parkinson's activities of daily life. So what I'm going to focus on now is the preliminary results. And I do need to warn that these are very beginning results because essentially we still have 4 to 5 people with Parkinson's that are completing the very final 6th month. In fact, they complete it this week or should do hopefully. So these results are subject to change. So this is what our initial sample looked like. So it's just giving you an idea of the kind of demographics that were included. One thing that is useful to point out is we did get a smaller sample than we were originally aiming for, more so in the aging controls than in the people with Parkinson's. So we were very fortunate that Parkinson's UK helped us to recruit, and so they were an amazing recruitment source, and we did get quite a lot of people with Parkinson's. Most of both samples were retired, the age ranges were similar, and the fall prevalence was about what we'd expect for both types of population. So for the people with Parkinson's, this is about 58% fallers, and for the controls, it's about 32% fallers. One thing that did slightly surprise us was the report of isolating during the pandemic. So basically, they were asked if they were at all isolating any period during the pandemic. That could include isolating because they had symptoms or someone in their household had symptoms, or because they were shielding or someone in their household was shielding. And we actually found that only around half of those samples reported any kind of isolation, which could imply that they were slightly less isolated than we initially predicted the sample might be. So now in terms of follow-up measures across the 6 months, we monitored their falls with the falls diary, and this is basically the percentage of fallers that we had. So the turquoise is people with Parkinson's and the yellow is controls. And essentially what we found was actually the percentage of falls didn't really change that much across the pandemic, which if anything is a good thing because we might have predicted that falls might increase across the pandemic. And just to keep in mind, again, we do have a few final responses coming in from the people with Parkinson's, so this time point at time 6 will change. One thing that we did see, though, was a number of converters, so people who didn't have falls at the beginning but did by the end of the study. So we had 7 of those people with Parkinson's and we had 5 in controls. And the other thing that slightly surprised us was how high a proportion we had of repeat fallers. So by repeat fallers, I don't just mean people who reported more than 1 fall at one stage. I mean people who across the months reported falls. And we had 23 of those in people with Parkinson's. So that's roughly half our fallers for people with Parkinson's. And we had 5 controls. And actually what we found within those repeat fallers is there were quite a lot of fallers that were reporting falls every month. The other thing to note about the data in general is that we did have a higher attrition rate within the sample of people with Parkinson's with falls. So we had 13 people that at the very beginning reported falls, but then actually didn't do any of the follow-ups. In terms of activity follow-up, like falls, we didn't actually see a significant change in the reported activity across the pandemic. So in the initial questionnaire, they weren't just asked about their current physical activity, they were actually asked how much time did they spend on each of those activities before the pandemic. So that's what I mean here by pre-pandemic and during the pandemic. So essentially, this didn't change across time for the people with Parkinson's on this slide. One thing that did change, though, is that by the time we got to the final follow-up, there was a significant group difference between the fallers and non-fallers, whereby fallers engaged in significantly less vigorous activity compared to non-fallers. Similarly, for controls, we did not see a significant change across time in the reported physical activity. However, we did find a significant group difference, and in this case, actually, it suggested that fallers were more active than the non-fallers. However, I have to caution, pardon me, about this result. So essentially, this is likely just due to small sample size. So if we look at here, I plotted all the non-fallers for the control group and all the fallers. And because we only have 12 fallers, this is why we're seeing this result. So these people aren't outliers. There are 5 of them within the full sample, but all 5 of these are reporting significantly higher motor activity than the highest person in the non-falls group. So basically, if we had a bigger sample, we probably wouldn't see this effect. In terms of the pre and post measures with the questionnaires, for Parkinson's, again, we did not see a significant effect across time on their clinical measures, but we did find significant group effects. So fallers performed significantly worse on the UPDRS2, which is the one related to motor symptoms, the freezing of gait questions, and the Parkinson's activities of daily living. In terms of the post-test, we saw this again in Parkinson's activity of daily living, but we lost this for the other 2, but we think that this is due to attrition and having a smaller sample size at this stage, because the plots still indicate that the fallers were performing worse. In terms of non-Parkinson specific measures, again, we did not find a significant effect across time. However, we did find a significant group effect. So people with falls were reporting higher fear of falling, higher attentional gait, and significantly lower risk taking. So they were more risk averse than the non-fall group. We also find this at post-test for fear of falling and for the gait specific attention profile, and actually state anxiety became significant at post-test, with fallers reporting significantly more state anxiety. Note, the reason risk-taking and trait anxiety are not done at post-test is because they're both trait measures. For controls, we didn't find any significant group effects, so there were no differences in any of the measures that we used. However, this is likely due to sample size. We did, however, see a significant effect just in the non-fallers, whereby their fear of falling reduced from initially at the start of the pandemic and later on. In terms of looking at the correlations then, the strongest correlation we found for the people with Parkinson's disease was in fear of falling. And this correlation is with the total number of falls that they experienced throughout the whole pandemic, or the 6 months of the pandemic that we measured with it. This is just a moderate correlation, but basically all of the tests that we found significant group differences in were correlated with the total number of falls. And they were also correlated again, apart from the UPDRS2 at post-test. The actual fear of falling correlation became even more significant, but still only moderate at post-test. In terms of controls, we found very few significant correlations in this group for total number of falls. The one thing that we did see was that at post-test, their state anxiety was positively correlated, again, a moderate correlation with the total number of falls. The final thing I just want to go over very quickly is some of the qualitative results. So again, I just want to caution that this is very preliminary. So I haven't done any kind of detailed thematic analysis on this yet. This is just some interesting things that we've pulled from the data so far. So within the Parkinson's group, we did see some positive reports of things that had changed during the pandemic. So for example, people basically referring to like less hustle and bustle about life, that they didn't rush around getting to this or that activity, and some people reporting benefits of being furloughed. Obviously, though, most of our sample was retired. But largely what we saw was negative reports of how the pandemic had impacted them. So these questions, they were basically asked at the end if there was anything that they wanted to discuss related to what they'd reported within their questionnaire. And so we had people talk about whenever they referred to feeling like they'd gained weight, they talked about snacking a lot more. And this person gave the example of they feel they do that because of loneliness. In terms of Parkinson's disease itself, we actually had a number of people report that they felt that their disease was significantly worse due to the pandemic. So 2 people reported that they only started on medication during the pandemic, and they basically blamed the pandemic for that. And other people reporting that they felt less steady on their feet now. And obviously this is subjective. We don't know if these people actually would have ended up on the medication at this time anyway. But it's still really important to note that this is how they felt. And so obviously this is going to affect things like it could affect their mental health during this time, and it could also just affect how they felt about the pandemic in general, and whether they blamed this for any increase in their Parkinson's disease symptoms. I thought this is a really nice, interesting example of something someone said in relation actually to their fall risk during this time. So we had one participant say, because I have stayed at home or in the garden, I haven't encountered different surfaces, heights of steps, etc. I have lacked practice and experience so that my body and mind are not so prepared, and this adds to my anxiety. So as a falls researcher focused on gait and balance, this was really interesting to me. But we also saw this in terms of other people reporting that they felt they were really missing out on some of their activities they would normally get to do outside of the pandemic, but they weren't getting to do currently. And then we also experienced some people talking about the level of isolation that they experienced. So for example, this one participant did their final follow-up in January. And so it was a whole 10 months that they hadn't been outdoors at all within that time. For the controls, we had slightly less qualitative data reported. These questions were optional, so they could say that they didn't have anything to report. However, one thing that we did see in a few participants was report of restricting their activities because of someone else, either someone they lived with or someone they cared for. And actually this person later on, a few months later, reported this, that they basically found a way to compensate for that lack of activity and a way to make it up at home. So just to finish up, obviously I've warned that these are just the beginning of the results. We've got a number of things left to look at. The first thing that we want to do is a survival analysis of time to fall throughout this follow-up period. We also want to explore differences perhaps in the types of falls. So maybe we don't see an increase or a decrease in the number of falls during this time, but rather we might see a difference in the types of falls, such as indoors or outdoors, trips or slips and things like that. Because different types can be associated with different levels of injury and things like that. And also we want to do then a proper thematic analysis of what we're seeing in these reports. We're also currently applying for ethics for the next project, which is going to look specifically at people who experience falls during the pandemic alone, age 50 plus. It'll take a similar format of being an online survey, but shorter this time. And they'll be given the option to opt in for an interview afterwards, which will ask them for more detail on their experiences during this time, because we do think this qualitative data is really important. So I just want to thank the team that were involved in this research, and also Parkinson's UK for sharing the study for us, and all of our participants. And a special shout out to my PhD student, Jodie Bontrib, because essentially this project wouldn't have come about if it wasn't for her, because she was essentially reporting that she was a little bit worried about a follow-up for her study at this time, and that gave us the idea to run this study. So thank you very much for listening, and I will take any questions.
That was a great presentation. Thank you very much. We already have 2 great presentations and 1 left, so bear with us. So I already keep track of two questions actually that I received through the chat, and I would like to add one. So I'm going to give it to you, and in that way you can answer them in the way that you prefer. So the first one, it was that someone who was asking if you have any data about this, if these people is living with others, maybe because you have the data who are the people who are isolated through the pandemic, but maybe you have data if they were living with one person at some point, or maybe two, and maybe it's different, the impact of that. And the other question that actually is super similar, like that one that I received, is about the conditions of the properties. How is the construction, that kind of stuff, if you have any data about that. And I would like to add one question actually to that. It's just about the diaries. I really like your research about the mixed methods use of those. And I would like to ask you, how was the experience to have been working with diaries? Because as you know, it's difficult to keep track of all of them. And maybe you can give us some insights of that process. That would be, thanks.
Thank you very much. So I'll go through them in the order. So we do have the data for whether they were on their own or not. So it's not something we've looked at just yet, but it's definitely something that we measured it for that reason. So we do hope to look at that and see if that affected either their full prevalence or what they report in terms of activity and things like that. For example, we know that typically if someone lives with someone, they can sometimes be a little bit more motivated to do physical activities at home, for instance. And then in terms of the conditions of where they were living, unfortunately, actually, we don't have any information about that, and it would have been really interesting, actually. So it's definitely something we'll consider in future, and it could be relevant to the follow-up study that we're planning. So I'm going to write that one down. And if the person that suggested it has any ideas about what way they think we should go about doing that, feel free to message me. And then the very final thing about the diaries was really beneficial for this project. We have had experience of using full diaries before, specifically my PhD student has used them. And we have found it difficult in the past because emailing them out to people and things like that can be very time consuming and hard to keep track of and stuff like that. These diaries for this study were much easier because essentially we use Qualitative for running this questionnaire, and you can program it that it automatically sends out all these and reminders and stuff like that. So we made full use of that system, and everything was very automated in that way. But the other key thing that we learned from this project about the full diaries was how beneficial having a qualitative element to it was. So it's quite normal in questionnaire-based things to just ask about like type of fall and like list things like slip, trip and stuff like that. And while we did do that, we then give them the option of giving details of their falls, and it's that detail that's been really interesting so far. So for instance, I didn't have time to talk about it in the talk, but we found that actually a lot of the falls that were reported during the pandemic occurred while gardening. And most people reported an increase in the amount of gardening that they were doing during the pandemic, which I have felt myself. I've definitely done more gardening this year. So that's something interesting that we could potentially look into and stuff like that. So thank you very much.
That was amazing. Thank you so much. I'm very cautious of time. It was really great to hear the interlink between physical and mental health. So that was amazing. Thank you so much. What I'm going to do is I'm going to move on to Professor Andrew Clarke's presentation. So Professor Andrew Clarke, last but not least, Professor Andrew Clarke is based at the University of Salford with research focusing around sociology. He's held postdoctoral teaching and research posts at the University of St Andrews, the Open University and the University of Leeds. Professor Clarke's research focuses on links between the environment and well-being, and this includes research on neighbourhoods, communities and well-being, dementia and care environments and fire risk. Andrew has an interest in methodological development, including advocating for inter and cross-disciplinary research. He's been a member of several successful interdisciplinary research bidding teams and has received research funding from international, national and regional sources. So today's talk will take an in-depth look into the work currently underway, looking at the importance of locality for older adults in Greater Manchester and changes to community spaces in COVID times. So I will now hand over to Andrew.
Thanks, Louise. And I think that Suzanne is going to bring my slides up. Brilliant. So there they are. So thanks very much. Thanks very much for staying online, everybody, to listen to me. So my name's Andrew, as Louise was saying there. The title of my talk, Familiar Places in Unfamiliar Times. I'm hoping it might be something that we all can kind of relate to, not just in terms of the sorts of places that we look at, but also, for me at least, research too is a kind of familiar environment, a familiar sort of place, which I have found perhaps less recognizable over the last 12 months. So what I want to do, I'll try and keep to the time allocated to me, but I want to reflect on two research projects. One that actually came to an end just as the COVID lockdown started in March last year, and then a second that was due to start on the very same week that we went into lockdown, both of which are actually variations on a similar theme, which is around how local places, or what we might want to call neighbourhoods, matter to people as they age. So if we could move to the next slide, please. So I'll start counterintuitively with an ending. This is a project that had been funded by the ESRC and the NIHR and involved a whole range of other people whose names are on the screen there, which was around how neighbourhoods mattered for people living with dementia. Some people on this call may have heard me talk about this. It was quite a long-running project that was ostensibly about how people who live independently in the community can find a degree of support from other places and other individuals who they experience locally, and also around how people who live with dementia in the community experience their own neighbourhoods. And this to me became a really familiar sort of place. The research itself, I'd become very familiar with the key findings, some of which are listed on the slide there. And I felt like I knew very much why neighbourhoods mattered for those people that we spoke to. We talked to about 130 people, either living with dementia or supporting a loved one or a friend to live with dementia from across Greater Manchester, from in Scotland and also in Sweden. And we found that actually neighbourhoods mattered because they provided a sense of connection, that it was important that people could get out and about, that people were able to maintain a sense of routine and habit, and that those routines and habits involved being seen in and being able to engage with and interact with other people and other environments outside of the home. And what we also started to see is that through processes of routine and habit, through kind of acts of kindness, through a sense of individuals living with dementia being recognised in local places and local spaces, then so too if the unexpected happened, or if people encountered issues that perhaps as a result of their dementia they found more challenging, then there was various aspects of support that could help people to continue to maintain that sense of local independence. Next slide, please. But what we also found is, and this was an argument that I'd started to make quite a bit, certainly up until last March, is that neighbourhoods are very much seen as relational places. So I'd started to argue that neighbourhoods were not just the geographically fixed locations immediately outside our front doors, but for people living with dementia, they could be stretched over space and stretched over time. So there's a couple of quotations there on the left-hand side that talk about the importance actually of spaces being much more accessible, the importance of being able to use public transport, but also the ways in which people who were living with dementia were able to travel geographically much further than perhaps stereotypical assumptions might assume. But that was based very much on the ability to undertake regular journeys, the importance of engendering a sense of familiarity, be that through use of public transport, for example, or even the quotation on the right-hand side there, being able to repeat a very familiar walk, treading familiar routes, familiar paths. In other words, that these neighbourhoods were relational, not just in terms of how they're stretched over space, but how they can stretch over time, being able to maintain a sense of rhythm. Next slide, please. And then sort of we've been working with a number of older people and individuals living with dementia and also community groups to get some of these ideas out, and we produced a series of booklets that were being circulated across Greater Manchester and beyond. That was all about how local communities and local neighbourhoods could help people living independently in the community. Then, of course, the pandemic arrived, and to state the obvious, there were disruptions and there were suspensions, not just to research, but actually to people's everyday lives, that we got a real sense of what became important. And perhaps what became less important was my own research and my own desire to circulate these various booklets, for example. But the other thing that happens is that research itself can become disrupted, that what I found as kind of familiar arguments I wanted to make about neighbourhood spaces perhaps no longer seem to fit as neatly as they wanted to. So, for example, in the dementia literature, there's a view that of a kind of a discourse of a shrinking world, that for people with the condition, then their ability to get out and about, but also people's social interactions can start to constrict. And my own work had started to really counter and argue against that narrative, to call for a need to try to understand places much more elastic, to develop this much more, as I called it, relational sense of neighbourhood belonging. But with COVID, we start to see that with social and physical distancing, that people are no longer able to get out and about as much as they could, that people were advised not to go out and about. And we had a real reframing of vulnerability, such that even the idea of getting out and about in local spaces, which I'd started to argue was so important, was perhaps seen as much more risky, as could heighten vulnerability, for example, where even various movements such as the age-friendly movement or the dementia-friendly communities movement could start to be seen as actually perpetuating a kind of risk to older people. And what we start to see there is a couple of things. First of all, there's a kind of disruption to common narratives that we present from research. And second, I think there's a potential homogenization of the aging experience, whether that's for people living with a condition like dementia or not. But what we also start to see is that as a researcher, I found myself haunted by participants. I found myself thinking back to all those individuals I'd talked to on that research project and thinking about what was happening to them, what kinds of things were they going through, particularly given the stories they told me and the researchers about how important it was for them to be able to get out and about. And the next slide, please, Suzanne. And at the same time, just as that research was coming to an end this time last year, I was also about to start a new project for Inspiring Communities Together, which was part of the Age-Friendly Salford team. And this was all about how older people could continue to be involved in various age-friendly initiatives, particularly across Salford. So at this point, this is a new project that we were due to begin. Importantly, it was not about people living with dementia, it was about older people, and I do not want to start inferring or conflating aging and living with dementia. But this too was a project about how geographical localities could support older people. The project was due to start, I think, on the 23rd of March. So it was due to start the very day that we went into lockdown. So I had to, myself and the team there had to very quickly think about what we had to do. We spent some time thinking that maybe lockdown wouldn't last forever, that things would get back to normal and then the project would start. And then as spring turned to summer and summer turned to autumn, the Inspiring Communities team kind of started to chivvy us along and reminded us that actually we do need to do some sort of research. And so we changed the focus of what we were looking at, and we started to undertake a kind of evaluation really of the shift to remote support delivery for older people living in Salford. We started to look at the ways in which the Age-Friendly Salford initiative had moved online. Next slide, please. But what we also very quickly found is you can't actually start to talk about that shift to online delivery and online support without actually hearing people's stories of COVID. And what we found is while the project was not about older people's experiences of lockdown, this was what many older people told us. So the work we were doing here involved online data collection, and also some telephone interviews as well. We held focus groups and interviews with around 19-20 providers and also 24 older people who had engaged in some way with these processes. And what we found is that from those older people, and all the quotations on the screen there are from older people who we spoke to, is a real sense of potential isolation from COVID. I'm not saying that COVID and lockdown created isolation and loneliness, but there was a real sense of the potential for that to happen. So the first individual there, for example, talks about how they stayed at home for 12 weeks, how they didn't go out, how they watched TV and got everything through the news and social media, how they became too scared to go out. And you can start to see some of the difficulties associated with that fear. The second quotation there, someone telling us how initially they started to go for walks around the block, but then they started to wonder, well, what was the point of that just to go out to come back home? And you start to see there a sense of a diminishing sense of purpose. And then you also find there this idea of people becoming stuck at home and the sort of boredom that was going on. Now, this idea of fear of leaving the home, lack of purpose, being stuck at home, these are perhaps things that everybody can relate to. But I think something is going on there with older people who are not necessarily engaged in employment, who have not necessarily got work, paid work to do all day, who perhaps don't have as much responsibility to look after children or to engage in homeschooling. But at the same time, we also know, as I say earlier, that aging is not a homogeneous experience. That older people have varied experiences of life and varied kinds of abilities, for example. Next slide, please. And what the age-friendly team and the Inspiring Communities Together team started to do was shift as rapidly as possible their activities, their support services, and their groups to online and other forms of remote connection. So much of the work we looked at were older people's experiences of doing this. And I guess what I need to say then is that the older people we spoke to are perhaps much more engaged than other older people. We've already heard from Jane, for example, there are really significant numbers of older people across Greater Manchester who do not have access to these online spheres. The digital divide, the structural inequalities are really acute and I think have been really emphasised by COVID, but whom we are talking to and the experiences I talk about here are from those groups of older people who we might kind of assume to be more engaged than others, at least when it comes to an online sphere. And what we found in terms of their experiences of engaging with some of these more remote and online activities is that they didn't necessarily go for the sake of the activities, but rather they engaged for something to do, something to fill the time with. So for example, the first quotation there, we see that actually this is a way of being able to speak to other people. That the benefit is really to remain connected and to stay together, to be able to communicate with other people. What we also found though is that there was a real opportunity for skill development. So older people that we spoke to talked about how their technology skills had really come on, and also how they were then being able to support other older people who they knew, their friends or relatives, for example, and helping them to connect to others, and also a sense of being able to use some of the skills they were learning by accessing the groups through the age-friendly Salford activities to start to stay in touch with other people as well. And then the final quotation there that we see is that actually being able to go online and join the groups gives you a sense of routine, a sense of structure to the day, gives you something to do and somewhere to be. And this to me really struck a chord because it spoke to exactly those same features that we were talking about in the previous study that had been around neighbourhoods for people living with dementia, around the importance of routine, the importance of having somewhere to go and somewhere to do. So what we start to see when it comes to the age friendliness agenda is that while it's great that the activities are very much focused on physical spaces, then so too is there perhaps opportunity for other sorts of age-friendly spaces to be developed. And that includes the idea that online space could also be a kind of place somewhere else for people to go and feel connected. Next slide, please. But what I don't want to say is that this shift to an online world represents a panacea. It's not all rosy. It's not all fantastic. The silences and the absences are really quite definite here. Remote delivery can certainly be empowering and it can be inclusive for those who can engage or are supported to engage, but it can also be really disempowering. It can be really exclusive. A report I read last week suggested that in 2019, around 57% of all older people aged over 75 in Greater Manchester were not online. The numbers were around 23% for those people aged over 55. So we're really aware that actually, even absent from the work we've done, has been a whole range of different groups of older people who are not engaging in the same way. And the Age Friendly Salford team, to their credit, are very much aware of those groups and the need to reach and support those groups too. But there are other sorts of silences and absences going on. So, for example, the first quotation on the screen there, an older person telling us that the Zoom, they very much talk about Zoom meetings where a lot of this activity happens. They've bridged a gap, but it's the no face-to-face thing. You're still sat there staring, watching people. You're all just sat there, but you're still alone, aren't you? And then other talk from older people about how they had friends and relatives who wouldn't go online, who really struggled to engage. And on top of that, you know, we are really, as I say, really conscious of those older people who don't have access to the internet, who don't have technology. There are also issues around language that can create various challenges as well, for example. And those older people we spoke to talked about the worry, not just of themselves within COVID, but those other older people that they no longer feel able to contact. Those older people who they used to see at various activities or round and about or on the street, who they no longer see and have no means of getting in touch with to check if they're okay. And the next slide, please. And another set of absences that we see is really something around the kind of the embodied interaction that comes with being in the same room or being able to travel to meet up with people. So, for example, people tell us that actually you can't really have a natter with people sitting next to you. You can't really maintain or build new sorts of friendships online in the way that you can do other kinds of processes. There's a real sense that actually these online platforms might fill a gap for the time being, but that there was a real hope and an aspiration that this would not be forever. And here we did find a little bit of tension, I think, between some of the providers of services who were talking about the need for blended delivery and the real opportunities that this can afford, particularly for those older people who find it more difficult to leave the home, and older people who were telling us that actually they don't really want any more Zoom meetings. Of course, it's context specific and longer term things might change. But one of the things that emerged is that actually being able to get out and about is not just about going to a face-to-face meeting or to have a natter with people. It's, as that final quotation says, it's about the opportunity for a change of scenery. It's about being able to get the bus, it's about being able to get the tram, to be able to watch and to see the outside world. As that person says there, it's not just about interacting in groups, it's the traveling, it's the being outside, it's the being part of the world. The community, they said, is well missing, isn't it? And again, this really echoes what we've seen in that earlier project about the importance of local spaces. So the next slide, please. And so what we also start to see then is that there was very much an aspiration of things wanting to get back to normal. And again, this is something that, you know, everybody can relate to. But when we think about what does it mean to get back to normal, there seems to be very much a sense of being able to somehow get back into place. What we also found is that the older people we spoke to thought it was essential that the activities they engaged with, the groups they went to, the ways in which they were supported to get on with life were delivered by what they called local services and local people. In the world of kind of the internet, there's a really common motif, something of a cliche really, that it doesn't matter where we are in the world. We can join the MICRA seminar regardless of whether we're in Manchester or New York or somewhere else. But what we actually found is that older people talked about how essential it was that those services were still being delivered by, in our case, organisations from Salford. What we start to see is, first of all, there was something about trust, not just about knowing people and having an ongoing history or an ongoing relationship that creates and maintains that trust, but also, as that first quotation says there, there's also something about the sense that you're all just that bit closer. We all know each other, but we also know we are not too far apart. These are all individuals who are sitting, looking at their screens within a relatively close geographical proximity, or even, I suppose, just across Greater Manchester. But there you can see at the end that sort of aspiration. You know that you will see each other again eventually. And there's a real sense of difference between seeing people through the screen, talking to people over the phone, and seeing people face to face. And then the second quotation there, you know that by being able to engage in groups that are being delivered by people from Salford, so local groups for local in inverted commas people, we know that we're from the same place, we're part of Salford, you know that you'll get together at some point face to face, we'll get back to normal. I suppose what we can start to see is going online is about providing opportunity, not just for routine and structure to the day. It's not just about providing a kind of purpose or somewhere to be, but it's also about being able to maintain that sense of identity and a sense of belonging, such that eventually, or when things, to quote this individual who will get back to normal, face-to-face interactions can pick up. So my final slide, please. So to sum up, really, what I want to say is just COVID has really challenged how the older people we spoke to experience place, how places can be supportive, perhaps even, I want to say, where place is located. That sense of a networked or relational neighbourhood perhaps no longer really operates the way it did in those previous studies I talked about. Second, supporting older people by providers has required creativity, innovation, and a lot of work. And what I would add to that is actually also requires creativity, innovation, and a lot of work from older people as well. There's, you know, a lot of agency going on here to provide support to other older people. What we also see is a kind of unbounding of place. The idea that age friendliness can exist in a virtual arena just as much as it can in physical locations, and perhaps the real opportunity in the future to develop that a bit more. But at the same time, these silences have been so deafening. The absence of individuals who are perhaps unable to access online because of, for example, challenges with technology or the digital divide. But also what we see is that place continues to matter. Local places, especially in neighbourhoods, continue to matter, even if for the time being, that place seems to be located somewhere else, perhaps online or on a screen, or even in some other time, either in the past or more aspirationally, sometime in the not too distant future when things can get back to normal. So that's my 20 minutes. Thanks very much for listening. That's kind of the end of what I wanted to say.
Perfect. Thank you very much, Andrew. I received 2 questions, so maybe I go ahead and say it to you, and that way you can answer them. So the first one, it was if you could notice any difference by gender, race, or ethnicity in your research.
That's a really good question. The answer at this stage is we don't know. So this is a bit like Chesney. So this is data that is fresh off my computer screen. So we've just finished the last of data collection back in at the start of this month, actually. So we've provided our initial reports to the Age Friendly Salford team, but one of the things that I think it'd be really useful to follow up with are these issues around gender, ethnicity, and those other kind of intersectional domains. It's something that we will definitely look at.
Yeah, that's great. Well, thank you very much for doing that so fast. The data collection was only 1 month ago. So, and the other question that I have is if there is any next steps of this research, because apparently it was not so clear if you have anything else to do later, or if you have any plans to go ahead.
So so there's a couple of things in terms of next steps. So we reached we're in the kind of dissemination stage. So this actually is outside of the Age Friendly Salford team. This has been the first public airing of the data. So the data, I think, has perhaps been as nervous as I've been about presenting it to strangers. What we are now going to start to do is look at actually, getting some of these core messages out across GM to hopefully to some of the providers. We plan to return. Well, we are returning to some of the groups where we recruited and talked to some of those older people to talk to them about what we've found. But also, what we're really keen to do with the work is to see this not as a kind of end point. So we did this research during COVID and now it's finished, and wasn't it awful, or weren't there some possibilities, or we all can't wait for things to change again, but rather to engage more in conversations about what it means actually to age in place. And so what we would really like to do in terms of next steps is to kind of advance or grow that idea of how we can properly have a discussion collectively with older people actually at the heart of those conversations. About what aging in place and aging online and in other sorts of places means, who's in part of the conversations and who actually is who finds it much harder to engage through those sorts of channels.
Perfect. Thank you very much. So I see that, well, I saw actually that Jackie gives 2 questions, and maybe this is the perfect moment in which Jane, I don't know if you saw that question before in the chat.
Yeah.
You have the
So I'll address Jackie's question first. So I didn't say too much about the design of the studies. So you're right to ask me about that. So we didn't have control groups. It was very much more an interpretivist kind of study around people's lived experiences. And the other thing that we were very keen to do we were very aware of the need for the speed at which this work was to be done. One of the things that seems to have happened, I think, to research in COVID is that everything is both slowed down and simultaneously had to be done incredibly quickly. So we didn't have sort of control groups, for example. And as I say, age, gender, for example, is definitely something we'd like to continue to follow up on as we keep working with the data. Chesney also asks about social distancing and wearing masks, whether that will continue to impact on older adults. I think it will. I think one of the things that will emerge is how as a society, actually, we think about vulnerability. I think there will be something going on about how as a society we, the role that older people are able to have. I'm also really aware that I've talked about older people who are living in the community. You know, there is no address here of people in care homes, for example, or who are less able to engage. I think wearing masks for older people who, for example, might have hearing difficulties and who rely much more on lip reading, for example. That's been a debate in the press, of course, but that could continue to go on in terms of wearing masks. I suspect there will continue to be concerns around what is it safe to do. And there will be, for providers, continue to be that ongoing need to remain agile. And I think agile is a polite way to label all the stress and the time and the dedication and the goodwill, actually, that everybody has to put in to continue to support each other. And what I would add to that is actually the older people we speak to too, it's not about them being always the recipients of support. It's about giving back, and there's a real sense of reciprocity and supporting each other as well that you know, people are continuing to keen to engage with.
Perfect. Thank you very much. Jackie, I can see you there. If you want, you can unmute yourself and maybe ask your questions, because I saw that you have a super interesting question a time ago, actually, to Jane. No, I can copy and paste it, actually.
Oh, thank you very much. It's nice to be unmuted. I just wondered, and actually the question regarding the equality, diversity, and inclusion and the data, I'd actually posed that question for Chesney in her, and thank you for picking that up on yours, Andrew. Yeah, but it was actually targeted to Chesney, and how, whether that was part of consideration for your study.
Sorry, just unmuting myself. We actually realized, so this kind of comes under Andrew's, like the stress of doing studies super quickly, like getting your ethics in and designing everything and getting it done as quickly as possible so that you can do research during the pandemic. So in hindsight, we actually realized we did not ask about ethnicity, and we kicked ourselves whenever we realized we didn't. We were trying to avoid asking people lots of personal questions at the start. So we basically asked their age because it was part of the pre-screen. They had to be a certain age to be able to take part. And we asked about living circumstances and employment, because we were thinking about it in relation to COVID. But in terms of demographics, there was a lot of stuff that we didn't capture, and unfortunately ethnicity was one of those. But that's definitely something that will be covered in the follow-up study.
Okay, thank you. No worries, Andrew, at all. I should have said to Chesney. thank you. Your presentation was really interesting, both of you. I'm really glad that I was able to join. Yeah, it's so interesting. Lovely.
Thank you.
Thank you.
Okay, I don't have any other questions. I don't know if anyone else would like to add any comments or something like that, or
maybe if we don't have any more questions, I will finish on a reflectance point, if that's okay. So I think COVID's given us a really big point to reflect on the research that we're currently doing. And I kind of pose a question to everyone who spoke today. So if you could change anything in the whole field of ageing research, particularly with the audience that you've got, the majority will probably be PhD students. What would you kind of pose to them to try and change in the research and field right now?
Can I go first?
On you go.
It's a very simple answer, and it's ageism. It really needs addressing. And actually, in all our research, I think we have a responsibility to start to include broader audiences, because actually, I know Chesney, Andrew, and it is a real issue. When we first delivered our first booklet, it was very limited in its reach, and we knew that. We knew it was done at pace, but we always were committed. We used it purely as a means to an end. Get the first booklet out, it will generate a business case, we can get more funding, and then we work with Ambition for Ageing, and we made sure we went out to right deep down into communities that are really marginalised, enormously underserviced, and we asked them, is this booklet useless or useful? What's it missing? And now we've created translated versions based on what we were told. Also, an easy read version. There's an audio version. We've got a BSL version coming. We've literally listened and we made sure we're producing it. But I do think as researchers, we have a responsibility to make sure we are looking at ethnicity in everything that we do. But the one thing we do need to tackle nationally is ageism. And you'll have all probably have seen the UN call to action that was released I think it was just this week or last week. I would advise you, the World Health Organization, a global action on ageism. Do Google that and go and have a look at it, because that's the one thing that will change all our lives.
That is great. Thank you so much. Does anyone else want to say anything else? I'm going to run with ageism as the thing that we all need to go against. We need to change it. So yes, what I'm going to do is I'm going to finish our little session there then, if that's okay. I just wanted to finish up by concluding the session. So I hope that you've all really enjoyed the event and hearing about the research that's happening across the 3 partner universities. I'd really like to extend my thanks to the amazing keynote speakers that we've had, Jane McDermott, Jill and Elaine, Dr. Chesney Craig and Professor Andrew Clarke. And I'd also like to say thanks to the MICRA Executive Director, Professor Alistair Barnes, for introducing the event, as well as the MICRA team working behind the scenes. So that's Francesca, Suzanne and Kerry. And finally, we'd like to say thanks to you, the audience, for listening and participating in this event. If you'd like to find out about any more network opportunities and try to keep up to date with what we're trying to do, you can follow us on the Twitter handle at MICRA PhD Network and also our personal Twitters as well. So I hope you have a lovely remainder of your day. Thanks again for taking part. So thank you.